So hello everyone, and today we'll be discussing a spotter case, and this is an important case, and it is a very subtle finding. So here we have a 40-year-old male who presented with symptoms of vertigo and double vision since a week, and this is the MRI brain of that patient, and this is the axial section diffusion weighted images. It's difficult to identify here, but here we can see this hyperintensity here in the lateral part of the medulla on the right side. On ADC, there is no reversal as such. On flare images, we can see this hyperintensity here, subtle hyperintensity, which is seen on the right lateral aspect of the lower medulla, and even it is seen on the T2 weighted images. And these are the T1 weighted images where we can see that there is hypointense area. So this is the report that I had given, that the study showed a small well-defined area of signal alteration involving the right lower lateral medulla, which was appearing hyper-intense on T2 and flare images and showed brightness on DWI, which was likely because of T2 shine through because there was no reversal on ADC. The area did not exhibit any mass effect and did not show any blooming on GRE sequence. So it was possibly a subacute infarct involving the right lateral lower medulla, and hence the possibility of lateral medullary syndrome or Wallenberg syndrome was given looking at the clinical features. There were some ill-defined confluent hyperintensities in bilateral centrum semi-ovale corresponding to chronic small vessel disease Fazekas grade 2, and there was some age-related involutional changes as well. So what exactly is Wallenberg syndrome? So lateral medullary syndrome or Wallenberg syndrome is a clinical syndrome which is caused by acute ischemic infarct of lateral medulla oblongata. The most commonly it is because of the occlusion of the intracranial portion of the vertebral artery followed by the pica, that is posterior inferior cerebellar artery, and it is caused mostly by atherosclerosis of the vertebral artery or the pica, and in some cases it's because of the dissection of the vertebral artery or hypoplastic vertebral artery. So the clinical syndrome is as such characterized by Horner syndrome, double vision, slurred speech, and dizziness. And all these have a particular reason because in the medulla we have different nuclei. Because of the vestibular nucleus and the inferior cerebellar peduncle, there is ataxia and vertigo. And because of the trigeminal nucleus, there is ipsilateral facial numbness, and because of the sympathetic pathway, there is Horner syndrome, which is particularly seen in these patients.